Hello, I'm Dr. Aron Green of Seaview Orthopaedics. I am fellowship trained in surgery and disorders of the foot and ankle, and we are going to be talking about ankle sprains and instability. So ankle instability occurs after an ankle sprain where there's injury to the lateral ankle ligaments, or the ligaments on the outside of the ankle connecting the fibula to the talus bone and to the calcaneus bone. There are 27,192 ankle sprains in the U.S. every day on average, and a certain percentage of those will go on to what we call chronic instability. Chronic instability is where those ligaments don't heal at the right length and the ankle is still unstable and is going to give way, allowing the patient to re-sprain their ankles. There are in fact two different kinds of instability. One is mechanical instability, where the ligaments are torn and remain torn, or are at a length that's too long so it does not stabilize the ankle. Then there's functional instability. Functional instability is where the ligaments are actually healed at the correct length. The ankle is stable on exam. However, the tendons around the ankle are weak, giving a sensation of the ankle giving way, but not an actual sprain event. So ankle instability is diagnosed primarily on physical exam. Patient is sitting with the leg and not having weight put on it, and you look at a couple structures around the ankle. You always want to palpate or press on bony prominences. You want to press on the fibula, or the bone on the outside of the ankle. You want to press on the medial malleolus, or the bone on the inside of the ankle. And you also want to press on the base of the fifth metatarsal, which is that little bump on the outside of your foot. Those generally are non-tender, but inside that kind of area between the lateral malleolus and the base of the fifth metatarsal is usually swollen. And if you press on it, hurts, and that's exactly where the lateral ligaments are. On top of that, you want to do something called a drawer test, where you actually stress the ligaments to see if the ankle is in fact stable or not stable. If a drawer test is unstable, the patient will feel their ankle actually coming out of the socket a little bit, and also feel a little bit of a click as that ankle is moving. Almost all ankle sprains should be, in my opinion, treated non-operatively initially. Depending upon the grade of sprains, and there's 3 grades, 1, 2, and 3, treatment options become everything from immobilization in a brace that fits inside a regular shoe, to a more significant sprain utilizing a walking boot for a short period of time, and in very, very significant sprains, you can potentially thinking about casting for a short period of time. Sprains do well with rapid mobilization, so regardless of how bad a sprain is, around 2 weeks, I like to get the ankle moving, and if not already in physical therapy, really start physical therapy, and along this whole course start on anti-inflammatories as well as ice and other RICE type treatment, rest, ice, compression, and elevation. There are a certain percentage of ankle sprains that, despite adequate conservative treatment, and for me the minimum conservative treatment for an ankle sprain would be 6 weeks, but I really try to treat conservatively for a little bit longer, go on to have mechanical instability or go on to chronic instability. The options for chronic instability are to, 1, be permanently braced so the ankle won't sprain. But if the patient does not want to be permanently braced, the answer is surgical. Surgery is a day-stay surgery. Come in the morning, go home in the afternoon. Generally done under a regional anesthetic. There's no general anesthesia involved. We numb you from the knee down. That numbness will last for a period of about 20 to 40 hours, so you're fairly comfortable post-operatively. During surgery, we reconstruct the ligaments. So we basically take the elongated ligament, shorten it, and sew it back together. We'll generally augment it with some suture anchors and some fiber taper or a bioabsorbable type suture. And first 2 weeks for me is generally non-weight bearing in a splint. Historically, these injuries surgically have been treated for about 6 weeks non-weight bearing, but with improved technology and improved techniques, I'm currently getting most of my patients into a walking boot at 2 weeks and back into a regular shoe at post-op week 4. And starting therapy at post-op week 4. Generally, the right time to find your physician at Seaview would be if you feel as if after a sprain your ankle still feels weak or still feels as if it's giving way. That means something isn't right and that sprain does need treatment. Your physician at Seaview will initially treat you conservatively, bracing therapy, anti-inflammatories. Higher level imaging may be needed, such as an MRI if not getting better, but you do want to seek your healthcare professional here to get and optimize your treatment. for the simple reason if ankle instability is left untreated, it can rapidly progress to post-traumatic arthritis, which requires significantly more treatment and is considerably more difficult to treat down the road.